Golden notes: temporal arthritis, giant cell arthritis, GCA. GCA should always be considered in elderly patients with headaches, ocular symptoms, for example, acute monocular visual loss, systemic symptoms, and high ESR. Suspected GCA, glucocorticoids immediately, even before diagnostic evaluation by temporal artery biopsy is completed. It is also known as the giant cell arthritis. Temporal arthritis is large vessel vasculitis, overlaps with polymyalgia rheumatica. Histology shows changes with characteristically skips certain sections of affected artery whilst damaging others. It is a clinical emergency. It is more common in females. The female to male ratio is 2 to 1. Peak incidence is between 70 to 79 years, rarely seen in patients less than 50 years. Features: typically patient more than 60 years old. The greatest risk factor for GCA is aging, almost never occurs before the age of 50. Usually rapid onset, for example, less than 1 month. The headache found in 85%. Jaw claudication, 65%. It is a very specific sign for temporal arthritis. Visual disturbances in 50%. It is secondary to anterior ischemic optic neuropathy. 15 to 20% of patients develop permanent visual loss. Tender palpable temporal artery. Features of PMR, just like aching, morning stiffness in proximal limb muscles. There is no weakness. Also lethargy, depression, low-grade fever, anorexia, and night sweats. Large vessel GCA, subclinical involvement of the aorta and large arteries is frequent, a clinical consequence of which can be aortic aneurysm in 10 to 20% of cases. Investigations: raised inflammatory markers, ESR more than 50. In fact, ESR is less than 30 only in 10% of patients. CRP may also be elevated. ESR can be within normal range in 5 to 10% of GCA cases. Temporal artery biopsy, the definitive diagnostic test. There is skip lesions. So certain sections of affected artery whilst damaging others. An adequate length of temporal artery 3 to 5 cm should be obtained because inflammatory lesions may be present in a segmental fashion. A negative temporal artery biopsy can occur in up to 50% of patients, often because the sampled region was not involved in the pathologic process. Therefore, it is not sensitive enough to rule out temporal arthritis. Treatment should not be delayed while waiting for the biopsy to be performed. Note that CK and EMG are normal. They are also normal in PMR. The American College of Rheumatology requires 3 of the following for GCA diagnosis: age more than 50 years, near-onset localized headache, temporal artery tenderness or decreased pulsation, ESR more than 50, temporal artery biopsy is positive. Treatment: high-dose prednisolone. There should be a dramatic response. If not, the diagnosis should be reconsidered. Current BSR guidelines recommend uncomplicated GCA. There is no jaw or tongue claudication or visual symptoms, then prednisolone 40 to 60 mg daily. When it is complicated GCA with visual involvement and or jaw or tongue claudication, evolving visual loss or history of amaurosis fugax, Then IV methylprednisolone 500 mg to 1 gram daily for 3 days, followed by oral corticosteroids. Established visual loss at least 60 mg prednisolone daily. Urgent ophthalmology review. Patients with visual symptoms should be seen the same day by an ophthalmologist. Visual damage is often irreversible, unfortunately. As GCA requires long-term steroid therapy, bone-sparing agents like biphosphonate and vitamin D and gastroprotective drug like omeprazole should be prescribed. Also, low-dose aspirin should be considered as it has been shown to reduce the rate of visual loss and cerebrovascular accident in GCA patients. This was provided by the SSSM Study Smart Series for MRCP, your easy way to easy pass. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.